Welcome to one of our first webinar series that the conjoint program between MorePETs and the Canadian Association of Nuclear Medicine. And today we have an hour set aside for this talk, and welcome. I'm very impressed by everybody has joined. Today's topic, we're looking at PSMA uptake, latest developments in imaging and therapy. And this is going to be given by Dr. David Laidley. He's a colleague of mine, about 100 kilometers from where I'm working here, and he's at the University of Western Ontario, and he's the program director, Division of Molecular Imaging and Theranostics at Western University. He has extensive training and extensive understanding of medical isotope imaging and therapies. Been involved in multiple research endeavors, and I think we will get going now. And Dr. Laidley, you have the floor.
All right, thank you very much. And just make sure I'm sharing here. You can all see my slides and hear me? Perfect. Okay, well, thanks very much, Chris, for the kind introduction. So we'll just kind of get going here. It's PSMA update. So it'll be discussing, I think at a high level, generally some of the latest imaging and therapeutic advances, with hopefully some tidbits that'll be helpful for people in their practice. My button here is not working, but let's see here. So these are just my disclosures. I'm not going to go through all the objectives, but basically we're going to talk about PSMA PET imaging and therapy in the context of Canada, kind of review some of the current imaging literature as it pertains to F-18 and gallium products. I'm going to spend a little bit of time talking about the PROMISE reporting criteria, version 1 and 2, kind of go over some of the RLT landscape and updates of funding in Canada, and then briefly go over some topics around patient selection, predictors of response, and go over some up and coming impactful trends and research trials in RLT. And then at the end, we'll take some questions. So this is kind of the standard conventional prostate cancer imaging that most centers have. Bone scans, CT scans, and MRI. These are ubiquitously used across Canada and the rest of the world. I would say over the last couple of years, for sure, in my institution, we've seen significant growth in PSMA PET imaging. Many centers like mine have been involved in a number of research trials looking at the use of RLT compounds. But certainly the use of PSMA PET imaging is probably not as common as many other jurisdictions. So again, this is kind of, I think many of you have seen this kind of slide before. What is the PSMA target? It's a transmembrane glycoprotein, highly expressed in prostate cancer. It binds to the extracellular component, which is unlike, I guess, prostacyclin, which some of you may have seen or used many, many years ago, which was more intracellular. It correlates with ADT use, ARPI use, and progression to castrate-resistant prostate cancer. And once it binds, it is internalized. So again, the mechanism of delivering the radioisotope, be it therapeutic or diagnostic, gets it close to the cellular components for potential target for therapy. So why do we use PSMA PET imaging? This is just an example of a common patient that has metastatic, in this case, castrate-resistant prostate cancer. Very good signal to noise in terms of lesion detection. Many of you have used PSMA PET imaging agents. I'm sure have many anecdotal cases of lesions that are not seen on conventional imaging that are clearly seen on PET. And in terms of sort of I guess the more pivotal trial that has kind of demonstrated in a prospective manner the utility of PSMA imaging was the PRO-PSMA study out of Australia, 300 patients, looking at comparing CT and bone scan versus PSMA PET imaging. These are looking at high-risk patients, which is one of the cohorts that we have in Ontario. Primary outcome was accuracy, and in terms of the results, PSMA PET imaging resulted in a 27% accuracy improvement over conventional imaging. And in general, when you look at area under the curve, specificity, sensitivity, and pretty well in all instances, PSMA PET outperforms conventional imaging. So in the setting of high risk prostate cancer. Certainly, I think the NCCN guidelines has suggested that the use of PSMA PET imaging could be used to replace conventional imaging. The only caveat to that is, at least there's not a lot of good guidelines on how to use PET in the follow-up of patients in terms of response assessment. So this is a huge gap in the area of PSMA PET imaging, but in general, looking at staging and restaging, we generally have found that PSMA PET imaging generally outperforms conventional imaging. This is just a quick couple of slides on the PrEP registry. This is our Ontario-wide endeavor to move F18-based compounds into the Canadian market. Originally started in 2018 with PYL. They have since moved to PSMA F18-1007. Without going into sort of the specifics, they have numerous different cohorts, being cohort 0, which is high-risk staging, and then all the way up from basically post-radical prostatectomy, and then in every instance, cohort 2, 3, 4, 5, 6. Most of the times, these are looking at biochemical failure. Cohort 7 is kind of a grab bag of access to PSMA PET, and actually cohort 8 is one of the newer cohorts, which is kind of more the Pluvicto setting. So this was done through multiple centers in Ontario, still ongoing today. And what, just in general, similar to the PRO-PSMA, generally speaking, when they've looked at the results, generally favorable findings in terms of detection of disease in the local regional recurrence, oligometastatic and extensive metastatic disease. And then when they examined the results of, I think it was PrEP 1 or 2, it changed management about 58% of men. So again, very comparable results, maybe a bit more of a broad assessment of the utility of PSMA imaging in many different cohorts of patients outside of the high-risk patient population. So just a couple of slides on F18 versus gallium-68 PSMA. As many of you probably using in Canada, given that gallium-68 PSMA 11 is the only Health Canada approved product. As you know, this is primarily excreted through the GU tract. Other centers, such in Australia, have access to PSMA I&T. We did start off using DCF-PYL in Canada in 2018, but no longer using it as far as I know. I think it might be used in Toronto, but I'm not sure where that is in terms of development and submission to Health Canada. And more recently, there are multiple sites in Ontario using PSMA 1007, which is primarily excreted through the GI tract. So one of the theoretical benefits of 1007 is the decreased urinary activity. As you can see on the PSMA 11 here, there's a lot of urinary activity here, and this presumably is the tumor here, and not a lot of urine activity. So again, in theory, it's a better agent for detection of local disease. In terms of Canada, I'm not sure where PYL stands. Again, the benefit of F18-based compounds is ideally the ability to transport the agents. And gallium-68 PSMA obviously would require, generally would require an on-site generator or generator in your local area where it can be locally transported fairly quickly. There have been comparisons of F18-based PSMA tracers to gallium-68 PSMA 11. In general, the results sort of favor similar results in terms of detection of disease. There is some suggestion PSMA 1007 is less preferable due to a higher rate of benign bone lesions. From personal experience, I would attest to this being a concern for 1007. There's definitely a much higher rate of what they call unexpected bone uptake, or UBU. And this is just an example of a patient that I just saw recently. There's a couple of faint lesions in the ribs. There's another faint lesion in the femur and another faint lesion in the pelvis. This was performed in early August. There was some concern regarding possible early bone metastases, and this patient was considered for more systemic therapy. In this instance, the physician arranged to have a repeat PET study done with gallium-68. There still is the rib lesions, which many of us who read PSMA PET images will attest to, again, that there is a general high amount of benign rib lesions that do show up on PET. If they don't have sort of the more classic aggressive features and they have very low uptake, then I think many of us are willing to classify these as benign. These femoral lesions and pelvic lesions have disappeared on the subsequent follow-up. So again, looking at this patient, they have very extensive disease in the prostate, which you can see on both scans. This is the gallium-68, which has the urinary excretion, which you can see clearly here. And again, this is just another example of the more of the GI tract in PSMA 177. But the trade-off of getting the lack of the GU activity for F18 PSMA agent has the trade-off of having this higher rate of unexpected bone lesions. And there was a publication in 2021 that identified the sites of these unexpected bone uptakes that tend to occur in the ribs and pelvis. So something to be mindful of. There are some publications that have looked at cutoffs for SUV. I mean, I think between anything less than 4 for gallium PSMA agents relative to the F18 ones are considered more benign. So that 4 to 12 range, depending on the appearance on CT, is more of equivocal, and anything over an SUV of 12 has been more or less kind of, I guess, in one publication been considered more in keeping with metastatic disease. But again, something that needs to be evaluated further. And just looking at PSMA PET imaging in Canada, I did try to get some information online and through Nicholas regarding where one can access PSMA. So this may not be entirely correct, but in general, there's pretty wide access to PSMA PET agents across Canada. Some of them are privately being performed, and I think some of them are going to be moved to public. Newfoundland and Saskatchewan, as far as I could tell, there wasn't a PSMA imaging program. Maybe if someone's on the line can correct me at the end. And then there are multiple centers or provinces in Canada that are using F18 based products. Ontario and Alberta are reportedly using F18. So to my knowledge, these are the only 2 provinces that are using those. And I think in Ontario, it's PYL and 1007. I'm not sure about Alberta. In Ontario, in terms of obtaining a PSMA PET scan, there are a number of indications. We have multiple cohorts. We have up to 9 of them. If you're getting for those people who are in Ontario, if you have access to centers that are doing gallium-68 PSMA, which include multiple private centers in Toronto and I believe London, and centers in Toronto or hospital centers are also doing gallium-68 PSMA. So for the most part, these can be ordered without any significant barriers in terms of getting consent. But if patients are being referred to, say, our center, there is the option that patients can be consented in a clinical trial to participate in the F18-1007 trial, which introduces a slight delay, but it does add some capacity. So in general speaking, we have high risk staging, and then pretty well a lot of inflection points where there's biochemical failure, all the way down to PSAs of less than or greater than 0.1. So pretty reasonable criteria to obtain a PET scan. Whether your center has PSMA PET access or not is the other question, but as time goes on, certainly our center has improved its capacity, and I'm sure many others will. So how do we report PSMA PET scans? I mean, many people are familiar with other reporting guidelines for, say, hematology in terms of lymphoma, the Deauville criteria. I think these have been pretty well widely adopted across most PET centers, if not all of them. But are there PSMA PET imaging criteria or reporting techniques that should be considered? So there are these PROMISE PSMA reporting criteria that were initially developed in 2018. This has really helped to standardize the reporting. So there have this molecular imaging TNM classification, And they also use this PSMA expression score, which we'll go through in a minute. So the expression score is, I would say, somewhat, I won't say controversial, but it's not perfect. In general, we have different agents. So we have the kidney excreted agents here and the liver dominant ones here. In general, we look at things like blood pool, liver, or spleen for the 1007 or parotids, and we assign a score of 0, 1, 2, or 3. For many of us who read a lot of these PET scans, we come across these instances where patients have very minimal uptake in salivary glands, they have high uptake in liver, or the threshold between parotid and liver is not quite this sort of wide open region. Sometimes the threshold is, very narrow, and the SUV of the parotid could be 13 and the SUV of the liver could be 10. It doesn't really create a lot of equal separation between the assessment of the tumor. So it's not a perfect score, and I think over time, I think we're probably going to end up moving away from organ-based assessments and maybe start looking at sort of more standardized SUV values as a reference. I mean, they're not perfect. I mean, if someone has an SUV of 4.5 and the cutoff is 5.0, does that really have any significance? I'm not sure, but this is sort of the general template. In terms of local assessment, not to go through this in any great detail other than the fact that the original PROMISE criteria divided up the prostate into 6 regions, sort of down the middle and kind of into equal thirds. And then, there is some emphasis on trying to define how many lesions, and is there any extra prostatic extension involvement of seminal vesicles. On the right-hand side here, if you look down here, if you don't have a baseline MRI to compare to, in general, lesions were considered positive if they had a PSMA expression score of greater than or equal to 2. Anything less than 1 was considered negative. So pretty easy criteria to use. And when I go through the version 2, there are some important differences that need to be addressed. In terms of lymph nodes, the original PROMISE criteria kind of defined, common iliac into all the pelvic nodes as being sort of pelvic in nature. Again, looking at the PSMA scores, depending on where the nodes are, depending on what the size of the nodes are, and whether they're in common locations for metastases or common locations for benign causes, you can use the PSMA scores to help guide you in terms of your confidence level in assessment of benign or malignant. This is not definitely, by no means is it perfect. You can certainly have very tiny lesions that don't meet these thresholds that are highly suspicious and probably, in my opinion, are generally considered metastatic until proven otherwise. But again, this was sort of a first crack at using standardized reporting. And then, of course, there's division of metastatic disease into kind of pelvic, bone, and organ-based. These are just some examples of the PROMISE score in metastatic disease. So again, looking at bone lesion, we have a clearly sclerotic lesion here. We have a PSMA avid lesion here. Anything over a 1 was considered positive. And then you start getting into sort of more equivocal findings. This kind of probably looks more of like a benign lesion with low-grade uptake. So probably in this one, you'd probably consider this less than 1 and negative. Then we get into lesions that have no corresponding findings on CT. And of course, we have a very intense lesion prominent in the spine. I'm not sure if this is a PSMA score 2 or 3, but if this worked out to be a PSMA score of 2, based on the nomogram here, we would potentially consider this equivocal. Although I think many of us would probably consider this to be positive. Multifocal lesions tends to increase your confidence level, and the score can be lowered to a 2 or greater. But again, not a perfect score, and I think use of clinical judgment and obviously discussion at tumor board would be helpful in some of these instances. And again, you can have benign lesions, you can have degenerative activity at the end plates. This is just an example of fibrous dysplasia. So, the CT characteristics, the location, obviously very important for consideration of metastatic or benign. So the updates to PROMISE, there are new updates that have been submitted and are commonly being used right now. So this is PROMISE version 2. There is updated in molecular imaging TNM for whole body staging and expression score. There is a reporting for PSMA expressions score as a tool to annotate certainty of diagnosis and the potential for RLT. And one of the more key points I want to go through today is looking at the patterns of expression within the prostate gland. And now there's now a 5-point scale, which is called a primary score, which is kind of in addition to the PROMISE criteria. So I think we have to be more familiar with this and try to incorporate this into our reporting. So just looking at the PSMA expression score version 2, all I will say is that in general, if you read these, it's not that different than what it was before. We still use reference organs, blood pool, liver, carotids. There's minimal differences here. They recommend the PSMA score only be applicable to lesions greater than 1 centimeter. Anything more than 2 is regarded as suspicious on a per lesion basis, and generally you want to have a PSMA score 2 greater than 2 for RLT, and also more of an emphasis on the reporting of the highest and lowest PSMA scores within a patient to kind of give you an idea of what may be the expected response to RLT. And if they have a mix of tumors that are high and low expression, then perhaps there may be other therapies that may be more appropriate at a certain time. PROMISE 2 in terms of nodes, in following the AGCC guidelines, there is now a separation of nodes in the common iliac chain to be excluded as a pelvic node, which I guess for people who read pelvic imaging, this is probably a no-brainer. But when the original guidelines were submitted in 2018 or finally approved in 2018, we would include common iliac nodes perhaps in the pelvic nodal basin. So kind of more falling in line with the recommendations in terms of surgical management of these patients. So looking more in detail at the PROMISE version 2, looking at the intraprostatic lesions. So these are just examples of types of uptake that you can see on PSMA PET scans. We have sort of bilateral uptakes, more centrally. We have some transitional zone activity, and we have this very prominent peripheral activity. So, under the old PROMISE 1 version, we were looking at PSMA uptake in terms of its expression score and defining our likelihood of positivity and malignancy based on anything over 2. So this is kind of the old version. Anything equal to or greater than 2 was considered positive. Anything less than or equal to 1 was negative. The new version takes into consideration sort of pattern, location, and intensity, and has been shown to improve the diagnostic sensitivity and specificity of PSMA PET scans. So we'll just go through a few examples. So just to be aware, I'm not going to go into this any detail, but if you sort of slice the prostate gland into different regions, we have sort of the outer area, which we call the peripheral zone. We have the central area, which is kind of present in the base to mid. And then we have the transition zone, which exists from more the base to the mid. And then when you get to the apex, it tends to be just more peripheral zone. So just keep that in mind. It's very difficult to perhaps qualify whether it's transitional or peripheral or central on the use of PET-CT only. But these are kind of like in your head, keep these in mind. If you do have a diagnostic MRI or a pre-treatment MRI, you can refer to the imaging and looking at the PIRADS to give you a better idea of where the uptake is. There's definitely going to be difference between lesions that are considered suspicious on MR and lesions that are suspicious on PET. I have seen, the congruent kind of findings, and then I can find many examples when I've read some PET studies and looked at MR where there's abnormalities on PET that are not described in MRI, and MRI abnormalities that are not seen on PET imaging. So, there may be some thinking that the higher PSMA expression lesions are likely the more aggressive lesions. And in some cases, biopsy proven disease on one side of the gland, for example, may not be seen on PET, but may be very low volume and maybe not seen on PET because of the tumor burden. So these are the different primary scores. So we have this sort of no uptake, which is probably the easiest one to look at. I mean, there's nothing to see, so that's a score of 1. We have this sort of more symmetrical transition zone uptake, which is considered more benign. We see this often with BPH. We have this central zone activity, which is, this would be the more typical pattern. You know, they do describe that if it extends more into the periphery of the tumor, this upgrades it to a primary score 4. I would say it's probably very difficult for many readers to kind of know what that extension is, and is it going to go from more of a benign score 2 to a score 4. So perhaps over time, as we all develop more expertise and get more familiar with comparison to conventional imaging, you know, these types of things will improve. But certainly, probably a very hard one to qualify if there is some activity close to the periphery. And the other thing you have to remember too is that patients often can move. So you have to be mindful of the registration of your PET and your CT. So what may be considered, central zone may actually be peripheral zone if it's not localized very well. And then we start getting into more of the malignant categories, looking at score 3, 4, and 5. 5 is kind of the more classic one. You have a very intense lesion. Peripheral zone, this is kind of, again, looking at the periphery of the gland. There's a positive lesion. The one caveat for peripheral area is that there is no minimal intensity for description of a abnormal lesion in the peripheral zone. So anything that's slightly positive in the periphery of the gland, by definition in this score would be score 4, and which be considered suspicious for involvement, unlike the other criteria which would have required the uptake to be greater or equal to 2. And then we have this prominent focal uptake in the transition zone. In general, they wanted to see that the uptake is greater than twice the background. So you can see prominent uptake in BPH. So in order to increase your specificity, generally you want to see twice the normal background in the transition zone. So when they looked at comparison of the area under the curve, using the primary score, taking readers that were experienced but blinded to the MR and vice versa, there actually was improvement in detection and qualification of malignancy within the prostate gland using the primary score versus PIRADS. And then there's obviously the benefit of using both primary and PIRADS or MRI. And of course, the combination of the two is considered in better. I'm not sure it's how much more superior it is to the primary score only, but in general, they perform both very well. And in terms of detection of lesions, PET using these other techniques, such as looking at location, intensity, and distribution, is important for qualification of malignancy or not. So now that we've kind of touched on the imaging component, just move into the theranostics component. So, and this is the typical metastatic castrate-resistant post, multiple treatments, post-taxane, progressive PSA, nodal and non-nodal disease. Obviously this is the Pluvicto indication. I think many centers in Canada are very anxiously awaiting, notification of funding or not. This is the, the common paradigm, which I don't think I have to get into here with, the CNM community here. Just quickly kind of, set the tone. Vision 617. We all are familiar with this study. This is looking at the post-chemotherapy PSMA positive patients, randomized 2-to-1 versus standard of care therapy. Again, improved overall survival. Generally favor looking at different subgroups, generally favor PSMA over standard of care. Improvement in radiographic-free survival, time to symptomatic events. PSA responses were stronger in the lutetium versus standard of care. If you looked at therapy, the PSA rates were slightly better, and it's probably due to better patient selection. Quality of life was improved on PSMA 617. So, we are very anxiously awaiting to have, these drugs available to treat our patient populations. I think most of our nuke med physicians and treaters of prostate cancer have been using these agents under clinical trial for quite a long time. So just to kind of, if you're not aware, Pluvicto has been approved in Canada since August of 2022. We are now into September of 2024. It's quite a long period of time in terms of the gap between approval and funding. Just to give you an update, as far as I was hoping to have maybe some good news to share at this meeting. But as far as I know, there are currently ongoing negotiations. This is from the PCPA website as of a few days ago. There are still active negotiations going on with Novartis, and no final decision has been made yet. I do know of 2 private pay clinics in Canada, one in BC and one in Quebec. There might be 2 clinics in Quebec, I'm not sure. Roughly speaking, for people who are treaters of prostate cancer, if you don't know, the treatment cost around $27,000 per cycle for 6 cycles. RLT landscape in Canada right now, as of today, I believe that, again, the 2 private pay clinics, or at least private pay in Quebec and BC. The rest of Canada, I'm pretty sure everyone else is using RLT under clinical trials. People are looking at, Pluvicto. People are looking at PSMA INT. Some sites are doing actinium PSMA. I'm not aware of any self-pay policies across Canada. I know we did try to launch a self-pay policy in our institution, and this did not move forward. So really right now we're kind of stuck with clinical trial and private pay solutions. And just kind of on the last few slides, is PSMA PET a good biomarker in terms of response to therapy? This was a subgroup sort of analysis of the therapy data, which I didn't get through today, but this was looking at the treatment of lutetium-617 versus cabazitaxel. For those Australian studies, if you're familiar with them, they are heavy promoters of use of dual PET and FDG and PSMA imaging. Very heavily pre-selected patients, any patients that have discordant FDG positive lesions, or even FDG positive disease that exceeds PSMA, these patients would be excluded. Some of this explains why some of their PSA rates are probably improved relative to, say, vision. And then, looking at proper good patient selection or different, more scrutinous patient selection. What they found was when they looked at, this is looking at PSMA SUV means. So patients that had a low SUV mean of less than 10, for both the cabazitaxel and lutetium, there tends to be, compared to those with greater than 10, there tends to be a better response with patients with higher PSMA SUV for both chemo and lutetium. So, if you had a choice, you obviously want to have a higher SUV no matter what, based on your PSMA score. And then when they looked at FDG volume or tumor volume, and they had a cutoff here of 200 mils for patients that had a lower FDG volume of disease. There was an improved radiographic-free, progression-free survival relative to those with higher FDG volumes. So, we kind of know, obviously, for RLT therapy and all radioligand therapies, if you can image them, if you can see the tumors and they express the target well, then generally speaking, they should do better. And how this will fit into the landscape of selection of patients and treatment decision to be determined. I know it's difficult enough for patients to get PSMA imaging, let alone the addition of FDG imaging. So again, until it's been established as being a critical component of patient selection, this may be more relegated to the research space. So just kind of the last couple of slides, just kind of go through an example of a patient to kind of bring up another point in terms of RLT. So this is actually a patient of mine. He's 78 years old, patient with metastatic castrate-resistant prostate cancer. He originally had climbing PSA, good performance status, no urinary issues, bone marrow's great. He's had post-ARPI, but this was in the pre-chemotherapy space. This was a patient that was or is currently enrolled in the PR21 trial. So this was examples of the SPECT imaging that was performed post-cycle 1 and 2, and you can see there's a bunch of lesions that are in the neck. These are lymph nodes, and then extensive amount of nodal disease in the pelvis, which even on cycle 2 showed significant improvement. You know, you can't see any lesions here, and the nodal disease is becoming difficult to see. This is his PSA curve, looking at sort of just prior to starting therapy, and then he had a very significant drop very quickly, and then a sort of a plateau. So he started treatment around December, which was here, and then he had up to 6 cycles. So by the time we get out to here, he's had 4, 5, and 6 cycles. So now this is a few months later. This is now looking at May. This is kind of the tail end of his treatment regime. He kind of bottomed out in June, and now he has this sort of trend up. Even though the numbers are quite small, his doubling time is estimated at around 3.3 months. Looking at his imaging, this is his baseline bone scan images, and this is his baseline PET, and this is his most recent CT. So he, you know, sometimes with treatment, we may see that this was PSMA positive and CT negative, and this could be an example of maybe a sclerotic treated MET. Unfortunately, I don't think that's the case. He didn't have any disease at this location at baseline. Based on the prostate working group criteria, he has 1 new lesion, which wouldn't qualify as being disease progression based on bone scan imaging, but based on CT imaging and PSA, it looks like he's definitely trending towards relapse within a few months after finishing RLT therapy. So this brings up a question around, you know, we do know that for all these patients that are being treated with PSMA agents, I mean, typically these are not curative treatments. These are treatments to hopefully prolong life and delay to more significant treatment, or delay things like fractures and other things. So, you know, what creates this resistance? I mean, there are many different mechanisms, which is too much to get into today, but, you know, radiosensitivity, heterogeneity of the tumors in terms of FDG and PSMA expression, and then maybe just not delivering enough radiation, or maybe it's not the right type of radiation depending on the size of the tumor or location. And there could be tumor mutational factors that which make them not more likely to respond to therapy. So, you know, now that we haven't even received approval for Pluvicto in Canada, but there seems to be more of a growing voice in the wilderness here to think that maybe just monotherapy with Pluvicto is not sufficient, or at least is not the best method of delivering therapy to patients. So I'm just going to quickly kind of go through the ENZA-P trial, which was published this year. This was out of Louise Emmett's group in Sydney, Australia. This is basically looking at the comparison of enzalutamide versus enzalutamide and PSMA therapy. They have this sort of dose adaptive PSMA therapy criteria built in. So again, it's not a standard dosing of 1 every 6 weeks, which is again something that could be discussed in greater detail. And when they looked at the PFS, there was an improvement in PSA PFS as well as radiographic PFS. Looking at 13 months here versus 7.8. In terms of response rates, PSA 50, much higher in the enzalutamide with lutetium. And when you actually look at PSA 90, again, significantly higher rates of PSA response of 90% or more in the combination group versus the standard of care group. So this is not a sort of a one-off. These are just examples of multiple other trials that are ongoing right now. This is the Alphabet trial, which is looking at radium versus PSMA INT. So again, radium looking at mostly bone lesions. You know, with the thought is maybe we could boost the therapy to those patients with predominant bone disease. LuCab is looking at the combination of lutetium PSMA and cabazitaxel versus chemotherapy. Again, thinking is that if there's heterogeneity in the tumors within the body, you know, your combination of your therapy will target sort of the heterogeneity, as well as there may be some sensitization or radiation mechanisms to improve the radiation therapy to treatment. And then just for those primarily interested in nuclear medicine, I guess more of a very early evolving trial, the Violet study. This is looking at the use of terbium-161 PSMA INT. This is a therapeutic that usually uses the Auger electrons for the treatment of disease. So again, a different type of radiation in terms of beta or alpha, which was more radium or actinium. With the thought is that if the patient tumors are relatively small, you would be able to deliver a higher volume of or higher amount of radiation in a smaller tumors than you would with PSMA 617, which the range is a little bit longer than even some cells. So you may be targeting normal tissue and not targeting the tumors you want. So again, I'm sure if this shows some promise, you'll start seeing some combination PSMA 161, PSMA INT, maybe with lutetium INT, and who knows, maybe there'll be patient studies we're looking at, combinations of Auger, alpha and beta emitters. We have different targets we can use. We also have different radioisotopes that have different therapeutic properties. So again, very exciting landscape, and I'm sure we're going to see more of this in the future. I think that brings me to the end of my presentation. So hopefully there'll be some questions, and I'm happy to answer questions.
Okay, that was excellent review, David. Thank you very much. We do have a few questions actually. One of the questions coming up is, what is the preferred time waiting post-injection for a PSMA scan? Should it be 1 hour, 2 hours in that room? When would we get the best bang for the buck?
I mean, I think anywhere in between. I think 1 hour is probably fine. I mean, you have to balance your patient volumes. If you have a very busy PET clinic and keeping patients injected and taking up patient chairs, obviously decreases your throughput. I mean, a lot of the times patients questions around PET scans are around should we give Lasix or not? We typically have not, but some centers do swear by using the use of Lasix to improve the detection of abnormal findings. I think for the older PET scanners that have sort of more older diagnostic CTs and the PET sensitivity is lower. I mean, looking at scans that we do today versus ones that we did a few years ago, I think having, for local disease in the pelvis, having a more state-of-the-art time-of-flight PET CT is definitely a huge advantage.
Okay. Another question we had was, can you be a little more detailed about the preference between gallium-68 and lutetium? Sorry.
You mean F18 versus gallium?
Yeah, gallium-68 and F18. Yeah. When would you use gallium versus F18 or vice versa?
Yeah, well, I mean, the easy answer is we use whichever one is available, because if you have no supply and you have lots of patients, you kind of try to image as many patients as you can. Personally, if I had no issues in supply, I personally would probably go with gallium-68 PSMA 11. I think it has a significant reduction in those unexpected bone lesions. I typically don't find the advantage of the GI versus GU excretion to be the most important factor in like not being able to find a small lymph node versus ureter is well, in some cases not as important as whether that 3 bone lesions that we're seeing on the ribs and the pelvis being metastatic is as important. So I don't know. I tend to like the gallium imaging. I don't think there's even though people would say like the positron range for F18 is better than gallium, I don't think it makes any meaningful clinical impact. That's just my preference. But I would say if you have access to both and you have a waiting list, you use both. I might suggest that if you have a bookings team, I might suggest that patients that are in the Pluvicto stage, known metastatic disease, that the F18 based ones would be perfectly fine. And maybe for the high risk patients looking at early staging of whether nodal versus just primary prostate versus bone, I maybe would triage those gallium if I had unlimited resources and people who could make that happen, but that may be asking too much.
Okay, good. Another question we have coming in is a combined trial of actinium-225 and lutetium. Is there any benefit to survival improvement?
I'm not aware of any studies that I've read out for actinium plus lutetium. I mean, in theory, I would think there probably would be some synergistic benefits to having both, but I don't think anyone has done that trial to completion. I'm not aware of one. If someone is aware, maybe they can put it in the chat. But certainly that combination of, you know, standard drugs like enzalutamide or abiraterone with RLT, and then you start thinking about, again, terbium or actinium, or even like chemotherapy. I mean, it makes some sense. So unlike, say, for Lutathera, where, you know, maybe the synergistic benefit of multiple therapies has not really shown to be a significant improvement, but for these men, you know, this is can be a very a disease that changes very quickly and can progress pretty rapidly. So I think trying to get the disease under the control as best as possible. And the one thing I did allude to, but didn't really get into any detail, is the idea of like adaptive treating. So for example, that patient I showed where he had a significant response very early after 2 cycles, in my head, it's probably beneficial to maybe give patients a treatment holiday and then start treating again once we start seeing that PSA come up, because we do know it's going to come up again. So if we could drag out therapy over like 1 year or 1.5 years, rather than completing all 6 cycles in 6 weeks per cycle, maybe that would delay the onset to, say, chemotherapy or other treatments.
Okay. We have time for one last question before you go to the second part of this presentation. And the question is, when you're doing an F18 PSMA 1007 scan and you find focal uptake, but without a CT correlation to account for that uptake, is there any SUV value that you could use to help to determine what you should do next with regards to follow-up?
So in those cases, I will usually look at the bone scan. So just to make sure it's not a lesion that's positive on bone scan. An SUV, I believe the SUV that's been quoted in the literature is like increased confidence of metastatic focus is over 12. Anything between 4 and 12 is considered kind of equivocal, and then less than 4 is usually considered benign. We have done a number of patients where we've had the F18 scans done, and then we've done an gallium-68. And in most of the cases, we have found most of the lesions have disappeared. We actually had one patient that had a F18 here and then went to Australia for a family vacation and had a gallium scan done in Australia at the same time, like weeks later. So we were actually able to get those images sent and compare them. So it did make a significant difference in patient management. So, you know, I think the clinical utility with the false positive rate with F18 1007 will have to be scrutinized, I think, in greater detail, especially if it's one of the only F18 products that we have available in Canada.
Okay. I'm actually told we have time for another question, so which is good. This is a question based on your patient, LC. Mm-hmm. And even though despite a minuscule PSA doubling time of about 3 months, is it accurate to say that this carries a much similar magnitude of pretest probability to a PSA that is very high? So in other words,
yeah, I mean, there's a new lesion on bone scan. There's a rising PSA. I mean, I think the question we have asked the question, like, does this mean anything? I mean, he's in the PER-21 trial, so does this mean he should go on to docetaxel now? I think the answer is probably no. He's clinically well. He feels exceedingly well. So I would think, and you know, most of my medical oncology GU colleagues, I mean, if they see this kind of rise, I don't think they're going to be too excited about it. So I'm not saying that this is actionable rise, but it does speak to the idea that we've kind of finished therapy and we're already starting to see some signs that maybe there's some progression 2 months after he's finished his last cycle. Ideally, you know, I think for most treatments, we'd like to see that the duration of, you know, stable PSA and no new lesions would be longer than 1 to 2 months. So again, I don't think it's actionable, but it maybe speaks to the idea of increasing the timing between therapies, allowing patients to present themselves with some early progression, retreat. Ideally, I'd like to see a drop in PSA again, and then follow that same pattern over. There are limits to how much treatment we can probably give, but I have seen slides from Mike Hoffman's group in Australia. They've given, sometimes up to 18 cycles over years, and have seen this kind of waxing and waning of PSAs and having good responses to therapy. So I think this idea of 6 cycles is kind of probably already outdated. And then we have the idea of monotherapy versus combined therapy versus multiple isotope therapy. The literature and the excitement for these products is far exceeding like the ability to get these approved and funded and into the market.
Okay. And our last question, do you see any use for in-house cyclotrons to produce PET-CT agents in the future, or do you think it's going to be more central based with distribution, like a spoke and wheel type thing?
I mean, both. I mean, again, London, we have access to Isologics, so that's in Burlington. We do have our own cyclotron, so we actually make our FDG here locally. I personally think that like developing the infrastructure to make gallium-68 on cyclotrons, which is something we have done in the past as part of a research trial years ago, and having the ability to make gallium to supplement maybe F-18 based products locally could be done. It's harder to ship gallium-68 products, but we have a cyclotron that can do it. I'm sure Toronto does. So maybe the idea of moving away from generator-based gallium-68 is an option, because I imagine over time, as the generators become more popular, the price will go up, and you can only image so many patients per day on a generator. So we do have our own limitations with gallium-68 based imaging, mainly capacity.
Okay. Well, thank you.